At this time, I would like to turn today's program over to Canada Health Infoway. The floor is yours.
Well, thank you very much, and welcome to everyone today. My name is Fraser with Canada Health Infoway. I'm the Group Program Director for Consumer Health and Innovation, and we're very excited today about our presentation topic, Pandora's Box is Open, and we have a huge following of people who have signed up for this webinar, so we definitely hope we meet your expectations in our delivery. I'm confident we will because we have three excellent speakers that are going to be addressing this issue and sharing information with you and some of the research that we have found. Just for today, for those of you that are having problems getting into our system today, make sure you use this dial-in number as opposed to using your computer. And then also, just as a notice for you, that today's webinar is being recorded. The reason that we're recording it is so that we can have it available on our website for people to review if they were not able to participate in today's presentation live. The other thing, and as Cole mentioned earlier, that we will be using the Q&A feature so that there won't be any voice questions, but please use the Q&A feature to ask us questions, and then we will make sure that they get addressed. My plan for today as moderator is we'll be going through each one of the presentations, and I will allow for a couple of questions after each presentation, but then we'll have the bulk of the questions at the end of all three presentations. However, don't be shy. Have your questions come at any time, and we will just queue them all up, and I will say them on each of your behalf. So because we have a huge following today, some of you may or may not know who Canada Health Infoway is. So I just wanted to say that our vision, healthier Canadians through innovative digital health solutions. We're a not-for-profit independent organization funded by Health Canada, and I urge you to visit our website if you haven't already done so. There's lots of information on there about Canada Health Infoway. As I already mentioned, this is how you ask the questions. Just click on the little Q&A box at the top and then type your question to all panelists. So today, we're going to talk to you about adolescent access. And in Canada, every individual has a right to their personal health information, or as those in the know call it PHI. As the use of consumer digital health solutions expand across Canada, it is evident that a better understanding of the application of this right to individuals under the age of majority is needed. It's complicated. So Infoway conducted research between December 2015 and March of this year, which focused on various aspects of adolescent electronic access to their own PHI. The study included a privacy legal framework review, an environmental scan and literature review, and finally a pan-Canadian survey and focus groups. Today our speakers will share the findings of this research with you, as well as first-hand experiences of an organization that developed its own policies to address this very issue. So we're going to start off today's conversation with a presentation or a discussion with Joan Roch. Joan is our Chief Privacy Strategy here at Canada Health Infoway, and she's been instrumental in ensuring that privacy is addressed through Infoway's digital health initiatives. In this thought leadership role, she spearheads the development of landmark reports, identifies emerging issues, and contributes to legislative development and promotes the importance of considering novel, practical approaches to privacy. So Joan, I'm going to turn it over to you and let you continue.
Thank you very much, Fraser. As Fraser mentioned, Infoway was really interested in learning more about adolescents' access to personal digital health information. And the first question we always ask ourselves is, what does the law say? Are there any restrictions that we need to be aware of? Or does the law simply enable the activity? Now, before I go on, I have to reinforce the fact that I'm not a lawyer. I've spent many years looking at laws for the purposes of policy and program development, but I am not a lawyer, and this is not legal advice that we're giving you. What we're sharing with you over the next few slides are simply highlights from our review of the statutes, and in no way should it be construed as legal advice. It's simply a starting point for you, and we hope it's something that can help you along in your thinking about the topic. And for more information on what I'm going to be sharing with you over the next few minutes, please do look at the report that is on our website. So first things first, what is a minor? Now, first of all provinces and territories have laws setting the age of majority as either 19 in 7 jurisdictions as listed up there on your screen, or 18, and that is 6 jurisdictions. Now, the age of majority is a threshold that's declared in law where an individual gains control over their own person, and generally the responsibility of the parent ends at that age. But, you know, there are also activities where legal age is set. Now, that can be different from the age of majority. Think of the activities related to voting. You vote when you're 18. Think of the right that you have to drive. That's generally at age 16. Now think of situations where laws ensure greater protection to those under the age of majority. Specifically, a child under 12 can't be convicted of a criminal code offense, and children between the ages of 12 and 17 are subject to the Youth Justice Act. Now, these special laws are based on the principle that youth are less morally blameworthy than adults. There's another concept in the mix here, and that is the age of consent. Now, this is generally the age at which a person has the capacity to agree to something. Now, in this regard, think of consenting to sex, consenting to medical treatment. And in terms of medical treatment, in 2009, the Supreme Court of Canada noted that one time, the common law, all children were considered to lack decisional capacity. They were automatically deprived of the right to make decisions about their medical treatment. But over time, common law recognized that children are entitled to a degree of decision-making autonomy that reflects their evolving level of intelligence and understanding. And this is called the common law mature minor doctrine. Another interesting observation that we made from the review is that laws evolve. In the 1970s and 80s, children actually stopped being seen as property of their parents and began to be viewed as having interests and rights that needed to be considered separately from their parents. In fact, I worked in the social assistance area in the 70s and 80s and recall the issue very, very clearly. We were faced with very capable young people who were on their own. They were operating outside the confines or constraints of their parents or family home. And they ended up being enrolled in their own right as mature minors for the purposes of social assistance. Now, when I reflect on this, it seems to me that the laws appear to attempt to seek a balance between respecting the evolving maturity of young people and of protecting them because of their lack of maturity in certain areas. The website for the Center for Public Legal Education in Alberta has a very, very user-friendly description of these different types of concepts and the age thresholds and why they exist if you want some additional reading. But let's now turn our attention to health information statutes. As Fraser mentioned a moment ago, health information privacy statutes in Canada do set out the right of access to your own personal health information. These rights include provisions to ensure that the formal written request for access is handled within a specified time period, and to ensure that disclosure of third-party information is not made during the access, and that it doesn't cause harm to the individual or another person. Now, when we looked around the country, we saw that in Quebec, there was only one province that actually identified an age threshold for this kind of access, and that was the province of Quebec, and they set it at the age of 14. In the other jurisdictions, no age limits were identified. In fact, the statutes reference individuals or persons. and it's those, that basis against which somebody can access their information. Now, 3 of the jurisdictions indicated that a minor, as that means, somebody not age of majority, can exercise their rights if they understand the nature of the matter and the consequences of the matter. And there were a few laws that actually indicated that the laws should not prevent ad hoc access. Now, the reason that I'm bringing this to your attention is because normally in the health information laws, they refer to formal access requests. And these are things that are written. You have to submit a written request to access your information, and the law says that it must be handled within X number of days. But the kind of information that we are talking about in this webinar is much more informal. It's the information that may be available to you through a portal to your own personal health information in a consumer health solution. And the issue that we're struggling with is that kind of ad hoc access and whether or not children can access that information freely. So that's why I pointed out the review that we did of the laws across the country, and we only found that there was a few laws, for example, Newfoundland and Labrador, where the law actually specified that we shouldn't prevent ad hoc access to information. Sorry, just having a bit of a problem. There we go. Now, the next slide has to do with consent to treatment, and the reason that I'm raising this is because it is possible that the use of information through consumer health solutions could involve consent for health treatment. And I just wanted us to be aware of the fact that consenting to health care treatment is a little more complex, we think, than just consenting to or having access to health information. It generally involves, it varies across the country quite a bit, which is why I didn't give you this long list of how different provinces treat consent to health care treatment. Generally, when you are asked to consent to health care treatment and you're under 18, the nature of the medical decision is taken into consideration. For example, is it a life and death decision that you're making as to whether or not you're going to continue on kidney dialysis or not? Or is it something which is more basic, as in, oh, I want to proceed with that blood test after all? So the nature of the medical decision is taken into consideration. And generally, there is a decision by the healthcare provider included, and the healthcare provider would basically assess whether or not the minor understands the nature and consequences of the treatment, as well as the benefits and risks of making the treatment to proceed or not. So you can see that consent to treatment is a little more complicated than just whether or not I can access and view my own information. Now, we also looked at, and I'm having a little technical difficulty moving this, there we go. We also looked at other social service statutes to see whether or not they could give us some guidance as to whether or not age thresholds should be set in consumer health solutions. And there was a great variety in what we found out. First of all, when we looked at information, so children's access to information, the statutes require that children 12 and older be given information about matters that affect them. And this could be giving them a report about whether the child is, if a report has been written about whether or not the child should get protection, there is a feeling that people over the age of 12 should have access to that report. In terms of adoption, statutes in all the jurisdictions required that the minor, generally at the age of 12, needed to be able to consent to the adoption. Now, there were a couple of jurisdictions where the age limits were lower. For example, Ontario was 7 and Quebec was 10, but the consent for adoption was addressed in all the jurisdictions. And then we looked at the right to make application under specific acts, to refuse protection or to be a party of proceedings, and generally the age threshold for those activities was 16 and sometimes 14. Now, to sum this up, what we can conclude is pretty basic. We do think it's reasonable for minors to want to access their personal health information. We know that these folks are very technically adept and are always on electronic means to access information, and it wouldn't be surprising that they want to have access to their health information through portals, etc. We also know that health information laws do ensure the individual's right of access, and that generally the laws in Canada do not limit that access on the basis of age. Only Quebec sets the access on an age threshold. And then we do know that other statutes set age thresholds, and we think that these may help organizations who are looking for guidance in permitting minors access to their personal health information. So that gives us the quick tour of laws across the country and how they play in this arena.
Great. Well, thank you very much, Joan. I think that paints a good picture and a good backdrop to the rest of our presentations this afternoon. So understanding the law is an important piece of this access for adolescents. If now what I'd like to do, Cole, if you could set up our poll. What we'd like to do as we sort of transition to our next speaker is have you each respond to this particular question around, does your organization have any policies or procedures related to adolescent access to their electronic health information? For those of you that aren't delivery organizations, you can answer the not applicable. But for those of you who are in this situation, we'd like to know, whether you do and what basis you've sort of designed it around, and if you don't or if you're working on them, that would be great as well. So if you'd answer those questions by clicking the appropriate radio button on the right-hand side of your screen, and I'll just give you a few more seconds before we close the poll. Make sure once you've hit the button that you click the submit button at the bottom right-hand corner of your screen, and that will make sure that your answer is submitted. Okay, Cole, if you would close the poll, and we'll wait for those answers to come up, and now we'll introduce our next speaker. So Kathy Fraser, a colleague of mine here at Canada Health Infoway, is a program director in consumer health and innovation. She holds a master's degree in health administration from U of T and is a Proxy certified change specialist as well as a certified health informatics professional. Over the past 19 years of her healthcare career, Kathy has worked in numerous roles within the health system, including 12 years as a frontline respiratory therapist. In her current role, Kathy is able to leverage these experiences and interests within a broad portfolio of the digital health initiatives she manages. So Kathy, if you'd like to take away this next portion. And looking at our poll, we can see that a lot of people found this it's not applicable. A majority of people don't have any policies, and then some have some, it looks like age and capacity-based are sort of neck and neck there in terms of those that do have yes. And then one organization actually has a policy where adolescents do not get access. So very interesting. Okay, this will, at the end of our this webinar, and once we follow up, we will be following up with a questionnaire around this. And so maybe as a result of this information, some of you will move from the no to the yes, perhaps. So thanks for giving us those answers. So over to you, Cassie.
Perfect. Thanks, Fraser. In this segment of the webinar, I want to share with you the findings from the two other components of research. So specifically on the environmental scan and literature review that focused on understanding how countries, jurisdictions within Canada, organizations and associations manage or recommend the management of adolescent access to their health information, as well as the Pan-Canadian Survey and Focus Groups, which focused on adult and adolescent perceptions on the rights of access to health information, willingness to share this access, and the mechanisms to enable it. The broad environmental scan and literature review consisted of an academic and grey literature search that included more than 85 articles, approximately 50 organizational websites, a review of national and international policy and practice guidelines, and then was further supported by 16 key informant interviews. The online survey of adolescents and adolescents from across Canada was conducted in January and February of this year, with just over 2,000 surveys completed, so about 1,000 adults and 1,000 adolescents responded. Following the survey period, we conducted a series of 9 in-person focus groups involving at least 80 people, and these were conducted in Vancouver, Toronto, and in Montreal in French. And each location consisted of 3 sessions, so 12 to 15-year-olds, 16 to 19-year-olds, as well as adults. The environmental scan revealed that there's no standard agreed-upon protocol or policy to manage adolescent access to personal health information. So across the country and internationally, there's quite a large variation in practice, although there's general agreement that individuals benefit from having this access, as well as the ability to share their PHI, such as improved communication with their care provider, improved care, and improved engagement in their personal health and wellness. The research also showed that organizational policies that deal with access to PHI also tend to relate to the assessment of the youth's capacity or their capability to understand, and we heard that from Joan as well. And as well, in some cases, whether they consented to that treatment for which the access is sought. So similar to the concepts that were mentioned about the Health Information Privacy Statute, many of the literature review sources identified the need to balance the adolescent's privacy with family involvement to coordinate and support their care, while acknowledging that most adolescents have evolving capacity with age and they tend to become more autonomous over time. Both the literature and key informant interviews and reviews supported the notion that adolescents who can make a decision about their treatment can also expect confidential access to their personal health information about that treatment. For policymakers, however, the fact that consent can be temporal or situation dependent can make it difficult to consistently link the concept of consent to treatment with the consent to access or disclosure of PHI. As such, many organizations or facility-specific policies can instead reference specific age limits for access to PHI, and we saw that in the polling responses as well. But when we think about a broader health system level with multiple care settings, with multiple organizations, such as with a jurisdictional level portal, this may be challenging to do. Through the Pan-Canadian Survey and focus groups, we learned that both adults and adolescents supported the idea that adolescents should be able to view their digital personal health information. In particular, older adolescents, so those in the 16 to 19-year age group, are more likely to say adolescents should be able to view their personal health information than adolescents who are 12 to 15 years old. And when asked why adolescents should be able to view their digital personal health information, both adults and adolescents equally responded that it was the adolescent's right to have access to information about their own health and body. We also asked adolescents what age groups did they think should be allowed to see their personal health information. The results found that the older the age group, the more adolescents say they should be allowed. For instance, 30% of adolescents thought 12 to 14-year-olds could be able to view their information, but 65% of adolescents thought those that were 15 to 17 would be appropriate for viewing, and 95% of adolescents thought those that were 18 or older would be appropriate. The prevailing view, and we hear it again through all the research, is that as an adolescent matures, it's more important for them to take increased responsibility in the management of their care. And this makes sense. You think about the 12 to 15-year-old group, few are involved in their care currently. Their involvement tends to be more around things like providing availability for appointments to their parents or identifying a need for an appointment. And when the younger groups were asked, so the 12 to 14 and 15 to 17-year-old groups were asked, why they thought they should be able to view their information, they were the same as the older groups and the adults. They thought that it was their right to have information about their own body. In general, though, when adolescents were asked if they had any concerns about younger groups viewing their information, they did cite that they were concerned that in some cases they may be too young.
Generally speaking, though, adolescents as a group thought anybody older than 18 or getting older towards that age were of sufficient age to understand and be able to view their information. And while they recognized that some of them may not understand all of the personal health information they may see, they still felt that the decision to view it should be theirs to make. We also asked adolescents to identify situations in which they would view their personal health information online. And the most commonly cited responses related to the ability to manage their health, so checking test results, when they were sick, or if they needed to help filling out forms to know their medical history. But in regards to the types of information that adolescents would check, both adults and adolescents agreed that they would be checking for future appointments, so what's coming up next for them. But interestingly, adolescents say they would check all more services than adults ever thought they would. And older adolescents were more likely to say that they would check all these types of information that was listed there on the screen. The focus group supported this and suggested that the reasons for checking this information online would largely be situational or to fulfill a specific information need. Few would check their information without some kind of a prompt like that. So determining who should decide adolescent access and how. Well, although there's general support for allowing adolescents to view their personal health information online, determining how adolescents should be able to view is not as clear. Nearly half of adults, or 42%, say this decision should rest with them. 22% of adults say the adolescent's age should be the determining factor. 20% say access should be automatic no matter what. And 7% of adults say it should be based on the adolescent's health status. In comparison, 66%, or 2/3 of adolescents, say the decision should be theirs. And 1/3 of these think that the decision should be based on age. And if we zoom in on that and look at the older age group, that number goes up to 40%, believing that age would be a suitable criteria. Within these age groups, though, we also found that more parents say parents should be able to decide if their adolescent has access compared to non-parent adults. And younger adolescents, so those that are 12 to 15, were more likely to say that their parents should also help them decide if they should view their information than older adolescents. The focus groups helped us to clarify some of these issues. The youngest group of kids are more likely to want to involve their parents in their decision about their information. And in these cases, many expected that they would share this information with their parents on a regular basis. But older kids were more firm in their position. This group felt strongly that they should be the ones to determine who could decide to see their health information. And for some of these, again, referencing back to the age concept, comparisons to other tasks like driver's license were barometers for an appropriate age to decide who can and cannot see their health information. So the hot question that comes up repeatedly is, should parents be able to view? Well, the majority of both adults and adolescents do agree that parents should be able to view the adolescent's personal health information. So 3/4 of adults and adolescents, so 79% of adults and 75% of adolescents think parents should be able to view this information. And again, as we heard before, more parents are likely to say they should be able to see this versus non-parents. But qualitatively, the focus groups shared a differing view on this. Having a parent automatically have access to the adolescent's health record varied as an adolescent aged. Those in the 16 to 19 age bracket were really a lot less likely to automatically want their parents to have access to their health information. And in some cases, it was felt that life events and health information around that time of life may be more sensitive or of a deeply personal nature. When it comes to views on confidentiality, there's a gap in the perception of adults when considering whom they think adolescents will share their information and whom the adolescents say they actually would share. While adults are concerned about adolescents sharing their online information with other people, adolescents are quite sensitive to this topic. Adults are not convinced, though, that adolescents will be responsible with sharing this information, but when prompted further, 42% of them couldn't identify a reason for this concern. Generally speaking, adults feel that if adolescents won't share their personal health information online, it's because they're hiding something. And they also, when we look at the parent group, they worry that they won't properly be able to care for the adolescent if they don't have this kind of information. All of that said, though, adolescents say they're just not likely to share their health information with any of them. 78% of them said they would only be likely to share it with their parents, and another 66% of them said they would only be likely to share it with other healthcare providers. As it may be expected, as we heard earlier, older adolescents are again indicating on this point that they're less likely to want to share with their parents than their younger cohorts. And to reiterate the point, too, about sharing with parents, adolescents are generally not concerned with having their parents view. Only 1 in 5, or 19%, agreed that they worried about this. Another quarter were completely indifferent, and 52% of them completely disagreed with that statement. 50% of adolescents agreed that they would not be comfortable sharing their health information online. So they really do see it as something that's personal and that they would maybe share with a parent or a healthcare provider or just keep to themselves. Regardless of what the parents were thinking, it could go to a best friend, a girlfriend, or a boyfriend. The adolescents were not agreeing or demonstrating this point. And interestingly, though, both groups do expect that parents will view adolescents' records up until adulthood. 75% of adults and 80% of parents expect that parents will have this kind of access. And again, younger adolescents were more likely to agree with that concept than the older ones. We had a little bit of fun with our survey respondents and our focus group participants and shared with them some life scenarios. So some of them were sort of non-sensitive, focusing on topics like juvenile diabetes or sports injury, and some of them were a little bit more sensitive, focusing on underage drinking and sexual activity. When we asked them the best approach for determining how access to online personal health information should occur, the research shows that it not only depends on age, but also on the situation. In the non-sensitive situations, the most common response was that adults and parents could both view this kind of information. But with the sensitive scenarios, adolescents were wanting to view the information and then decide if the parent could see, as well as that was equally split with agreeing to have both to view it. Not surprisingly, parents are more inclined to say that parents should be the ones to view it, or they should be the ones to view it and then decide if their adolescent gets access to this information. There's lots of ways for considering access to mature and minor, and Joan touched on some of the things that can affect this, such as age, capacity, independence. Although we know that capacity can depend on particular circumstances or change over time, legislation, et cetera. But we know that there's challenges with assessing this concept too. Some of our key informants shared thoughts that, it depends on the personal judgment of the healthcare provider. Every provider may be different, and the next provider may have different thresholds. And one informant wondered that from a solutions or technology perspective, even though an organization can develop a policy or give guidelines, the solution or the technology, is it always able to respect what you've put into the policy? So we're left with that question of how you build a system or rules that can account for this in the digital world. In moving to electronic records, there are likely different triggers for enabling access at a more systematic level, but these can raise new issues and potential inadvertent disclosure. There's pros and cons with all the options. For instance, if you select a universal cutoff age or maturity determined access when compared to the paper world, the system, quote unquote, has no experience with the patient or access to the provider to assess mature minor status. It may not be possible to assess each individual on a case-by-case basis, particularly if you're looking at a system that crosses more than one facility. Additionally, if you choose a universal age, this may not consider the capacity of the individual, but on the plus side, if it is the rule, it could potentially ensure a parent doesn't believe their child suddenly accessed a sensitive health service. As we heard even in our poll results, in some cases you may have minors that are being excluded from access altogether as the issue is deemed to be too complex or tricky to manage, but then there's the concern about denying access to health information. In some cases, in-person sign-up for electronic access may be required so that attributes of maturity can still be assessed, but this could be tricky again to do at the systematic level. So regardless of how electronic access is enabled, the question remains that it's appropriate to configure access to address confidentiality and make sure the policies that are put in place consider all of these factors as well as the functionality of the technology to ensure access and limit inadvertent disclosure. I'm going to pass it back over now to Fraser to introduce the next poll and then move on with the presentation.
Thank you, Kathy. Excellent. We do have a question for you, but while just before I do that, I'd like people to answer this current poll. So Cole, if you could set that up for us, please. Again, look at the question. So how do you think adolescent access to electronic health information should happen? The responses are there. Once you've selected your response, press submit, and then we'll show the results of that polling question. But in the meantime, Kathy, we had a question about billing. And so in a certain situation where if an adolescent is seeking treatment and then they're deciding they want to, you know, have their information kept confidential. But if that particular service isn't covered by an insurance plan or the, you know, the insurance plan of the province, the question is asking who should the bill be sent to, the parent or the adolescent? I'm not sure if we can actually answer that question, but I didn't know if you had any thoughts on that.
I don't think we can answer the question specifically, but that certainly did come up within the key informant interviews in the environmental scan and research, noting that that was actually a perfect example of inadvertent disclosure, where a child may have sought, you know, healthcare for a sensitive issue on their own. They're entitled to confidential access to that personal health information, but then the bill gets sent to the parent. So, for example, underage drinking, a child is intoxicated, gets sent by ambulance to the emergency room perhaps. They recover and go home without sharing that, but the parents get the bill for the ambulance. And so it is a question of how do we flag this information in the systems to prevent those kinds of things. And in other cases, the parents may get a notice that from an audit perhaps that a child has sought service in a certain area, and the parent may not know, but they are not necessarily allowed to have access to that information. So I don't think it's anything that's been solved yet, but it's certainly a need in the system that needs to be considered with technology and policy.
Great, thank you. So Cole, I think you've just closed the poll, so that's great. While that response is coming up, we're going to pass the ball over to our final presenter, who is Jennifer Gillert. Jennifer is a Senior Business Systems Analyst in the e-Health Department at the Children's Hospital of Eastern Ontario, CHEO, in Ottawa. She holds a Master's of Science in Healthcare Quality, Risk, and Safety from Queen's University. Jennifer has been involved with a variety of healthcare information technology projects across Canada over the past 10 years, largely in the pediatric setting. She has worked as an analyst for the HIMSS Level 6 ambulatory EHR implementation at CHEO and was the lead analyst for the implementation of CHEO's patient portal, MyChart. Welcome, Jennifer, and I turn it over to you.
Thanks very much, Fraser. So I'll go through my slides. I'll make sure we leave enough time to answer questions from the participants. I'm happy today to share our experiences at CHEO implementing a patient portal in a pediatric environment. I'll share the approach that we've taken to protect the privacy of our patients in this complex environment in the electronic world. All right, there we go, a little delay. So just a very brief overview of CHEO in Ottawa. So we're a 167-bed tertiary care acute care hospital. We see close to 200,000 outpatient visits at over 60 specialties at CHEO and provide care to Eastern Ontario, Western Quebec, and Nunavut. In terms of our patient portal, the technology we've implemented, so it's, we call it MyChart, and it's a tethered patient portal to our electronic health records that we use here at CHEO. The type of information that a user of MyChart here at CHEO would see would be upcoming and past appointment information, including reminders about upcoming appointments and summaries from previous visits. We can see health information such as test results, discrete allergies and medications, as well as health issues. And through MyChart, we actually can take updates to allergy and medication information that the patient or family might have before CHEO does. We share information about research studies that our patients are participating in, as well as growth charts, and we do secure two-way messaging through our portal as well. One important topic on the implementation of MyChart at CHEO has been the enrollment process. So how do we ensure that we get the right information about the right people with the appropriate authorization to process that request to access the personal health information to our pediatric patients? So we did develop an access request form that suits, regardless of the age or the situation of the patient, to accept the patient information and those that are requesting what we call proxy access to the patient's information through this form. We take the signatures as applicable, and I'll speak to a little bit about who authorizes what at the various ages on the next slide. But then essentially that form is, goes through a manual proxy access check by our health records team here at CHIO, and they look for things like alerts that we might have on file, potentially a child protection case, or any other privacy flag we might have on file about the patient. The legal guardianship is reviewed. It might be grandma that brought our patient into the clinic today and might fill out a form for access to this, but that doesn't mean that they would be able to have access to my chart per se. Do look for legal guardianship. The other, another key checkpoint in this proxy access review is for certain patient populations that we've identified where the access to that information may not be in the best interest of that patient. So our team looks at the health issues of the problem list of that patient and assesses certain the appropriateness of the request and escalates that as necessary. Essentially, that's intended to make sure that we, the information we're getting on the form is appropriate. And if that is satisfied, there is then an activation email that's sent to the person who's requested that with the information they need to be able to log into the system for the first time. Let's break down the approach that we've taken to date on the age categories for the proxy access, speaking a little bit to some of the topics earlier referenced in the webinar today. So between ages 0 and 11, the proxy can be granted full access to MyChart upon approval of that application process, and the patient would only have access with the permission of the parent or the legal guardian. Between the ages of 12 and 15, the proxy can be granted full access unless the patient advises us otherwise. And at the age of 16 or older, it's the patient who authorizes the proxy access, and it's only in that situation that the proxy is given access to MyChart. The little caveat here is that we are in the process of updating our release of information processes to change the default age of consent to release the health information to age of 12 later this fall. So some of the further safeguards that we have in place around these ages. So we have what we call checkpoints built to deactivate at certain ages to help protect, as Kathy was alluding to, some of those evolving the nature of the care that might be provided or the evolving autonomy of that patient. So the proxy access is deactivated at the age of 12 and 16, and at 19, somewhat concluding the care here at CHIO. But this is intended to prompt the re-enrollment of the proxy to evaluate whether or not it's still appropriate for that person to have access and whether or not the patient still wants that access to be in place. We do ensure that anyone who's requesting access does get their own account, and we do require a unique email address for each individual. The intention here is to help safeguard against the sharing of accounts, because once accounts start to be shared, we lose some of the ability to control the access and make changes on our end at CHIO. From a deactivation perspective, we did do a deep dive into some of these processes, considering what do we do when there's a report of inappropriate use. How do we ensure that a patient can request deactivation, and what occurs in a legal update? Let's say that there's a change in custody for those proxies that may be on file. There are a few different ways that deactivation may occur. The patient, right from within MyChart, could say, I no longer want this proxy to have access to MyChart. Through our privacy office, we may get legal updates that might lead to deactivation of a proxy. We have a process where a written deactivation request could come in, And as I mentioned, automatic at certain ages, we do deactivate that to prompt that reevaluation. From a technology standpoint, the processes and policies are a key component, but we also do depend on the technology itself to help support the measures we want to put in place. I'll summarize here a few of the key features from our experiences that have helped support this. The idea that we do create unique accounts for each user to differentiate each access. The fact that we can send expiry notification in advance of the transition ages to smooth over what needs to occur at each of those ages. The fact that a password can be changed at any time if patient made a shared access, shared password at one point in time, but no longer wants that to be the case. From within MyChart, you can change that password at any time. I mentioned the patient can deactivate the proxy on their own terms as well, right from within the application. We have the option for confidential messaging between patient and provider. So while the rest of the health information is consistent for what the patient or the proxy would see, we do have an option that the patient could choose to not have the proxy see that a specific message was sent. And we do restrict sensitive results from being released to MyChart automatically. So some of our lessons learned is the manual review of the access request forms in our environment has been paramount, validating that legal guardianship. We started a little bit down this path due to not having a great electronic way to do it without this, but it has proven to be important because we do get requests where it wouldn't be appropriate to allow that. The fact that our, like any other implementation, implementing electronic processes really does highlight existing challenges in the paper world. This, in part, has led to a reevaluation of the ages around consenting to the release of health information, and has led to more overall improvements in the future related to this. The last lesson learned I'll mention is just around the complexity of this type of information, these concepts. The fact that there's been so much interest in this topic, for example, it's not a straightforward environment, and there's a need for education. So in our case here, we do have volunteers in clinic. We call them our MyChart ambassadors that are available to answer questions. The enrollment form does have, certainly does prompt questions to fill it in the right way, and questions around who has access when. So that has been our approach to that. And similarly, on the clinical side, it can't be assumed that this navigating these electronic conversations with the patients and families having access is necessarily taught in med school. There is a need at the organizational level to improve the awareness around the ages and who has access to what, and help facilitate some of those conversations about what it means to have access to the patient portal and to share that with proxies. And that is all I wanted to cover. I do want to hand it over now back to Fraser so he can keep us moving along.
Great. Thank you so much, Jennifer. That was excellent. And you have generated a flurry of questions. So what I'm going to do is I was going to give a brief summary of what people heard over this call, but I think I'll just put that up there. This will be available to you when our slide presentation and webinar are uploaded probably within a week's time. So it'll be there for you to view and see this summary. Also on this next slide are a bunch of resources that you may or may wish to connect with. Again, once you get the presentation and have access to it from our website, you'll be able to click on those resources and read them to your heart's content. So now when it comes to questions, Jennifer, I'm going to be directing some of these to yourself, but all our participants, please feel free to type in some questions to any one of our presenters today. They each have a particular view on this information and have looked at the different aspects of this. So Jennifer, some of the questions that have come to you around your checkpoint procedure that you do at CHEO, is it an automatic or manual process?
It is automatic. It looks to the age of the patient and does send out a notification in advance, 2 months leading up to it. An email message or tickler message would be sent that the expiry would be occurring on a certain date, and to prompt that form to be completed again under the new kind of age considerations.
And if they don't respond, they're cut off, basically?
Correct, yep.
Okay, got it. Now, there was a question also about email addresses and what you collect for patients. And so our email addresses, such as those in the Hotmail domain and et cetera, do you allow those?
We do. So the reason we're not concerned about that is we don't actually send any personal health information to the email itself. We send what we call tickler messages that act as a reminder for folks to log in to see new information that would be available in MyChart, but all of the health information stays safe and secure within the patient portal bubble.
Okay, all right. Now, regarding the patient portal bubble, I think I know the answer to this, but we'll ask it. Some people were asking whether the access to the patient portal is only allowed within the hospital confines itself, but no, people are able to access this from their homes or from wherever they choose. Is that correct?
Correct. And we actually also have a mobile app that's now available as well.
Oh, cool. How do you confirm and verify a patient's ID, especially when it comes to adolescents who may not have sort of current what Air Canada would consider, government-approved photo ID?
So that's a good question. So none of the validation occurs in person. The form is filled out and it is sent to our health records team with the background in managing requests for personal health information. Not knowing the details of exactly all the steps that they go through, I guess my maybe cop-out answer is that they would validate that in the same way that they would have even a paper request. So separate from the access to the portal, they would complete the same type of validation that they would for any type of other request.
Okay, all right. And when someone is being set up on the portal, and so some of these are more information about the portal itself as opposed to Adolescent Access, but what method do you send that login information to the individual? Is it through email, through Purelator, through regular mail? How is that accomplished?
So when they're in clinic and they might fill out that request, they'll get a little card that gives them some information. It gives them their medical record number, and they take that home with them. They've filled out their form, and when we complete that request, they'll get an email that gives them a 15-digit activation code, and when they then click on that link from their email, to answer that part of the question, they're prompted for their medical record number that they received in person. In the email, they have their activation code, and they know their date of birth and their demographic information. So that, with all of that information, that authorizes or acknowledges them as them and allows them to create their own username and password for the site.
Okay, all right. So in our last poll that we did, just over half of you, or around half of you, agreed that sort of age is sort of the determining factor, and so that's certainly something that CHEO has selected. Cassie, what I found interesting in some of your slides was the fact that many of us perceive adolescents to actually, because they're so involved in social media, that they would just share their health information with anyone, yet the focus group showed otherwise.
The focus groups and the survey respondents showed that they would be much more careful with their health information. I think we've probably done a good job in educating this cohort coming through the public school system or, the education system initially, and then having these conversations at home about the importance of protecting yourself and watching your persona out in the social media. And I think that was reflected in all the responses that we saw. They were very careful in considering this information to be confidential and indicated that they wouldn't want to share it with a friend, certainly not with a boyfriend or girlfriend. And again, as the older age groups indicated, maybe not even with their parents. They talk about it with their parents, but they may not share it specifically even with them.
Okay. And Joan, regarding a lot of these laws, that are across the country, each slightly different. Do we know, has there ever been a challenge to any of these in this sort of adolescent or case, someone sort of coming forward and challenging them, or no, it's still so nascent that we haven't seen any of that in sort of the Canadian system?
As I said at the beginning, I'm not a lawyer, so I don't keep up with all the case law. However, I have not had any of these kinds of cases brought to my attention. So I guess my non-lawyer answer is no, there haven't been any challenges so far. I'm sure somebody in the crowd out there can tell me otherwise.
And Jennifer, this kind of this question sort of relates back to some of the legality of things. Is someone was wondering how at CHEO do you determine how is the legal guardianship verified?
So we have patient alerts on file when there are custody considerations. So we would validate that with the information that we have.
Okay, all right.
So, Fraser, I just actually saw a question come up on the poll there that had to do with mental health. And I do want to say we didn't look at the laws from the mental health lens. That would be a whole other area of work that probably should be done, because I do know there are questions in that area as well.
Okay, great. Excellent. Well, this has been a fantastic session. I thank you to all three of our presenters for giving us their time today and walking us through this. There is a lot of information that we've assembled. I think there's a lot more to be able to answer these questions specifically, and as Joan pointed out, there's not only mental health, but there's probably other situations, again, around capacity, around being able to access your information. I remember some as we were doing this, were saying, it's sort of at the beginning stages of life and then also near the end stages of life with seniors or people who are having some capacity issues. So we hope that what we've presented today gives you some information to chew on, to actually sort of take back and use in your own organizations if that's applicable. We will be sending out a follow-up questionnaire to this webinar, and we appreciate you taking the time to answer it. Some of these will help us think about how we move forward with this and how we actually provide you with even more information. But today's session is drawing to a close. Again, thank you to our presenters. Thank you to the audience out there. Your questions were great, and I wish you all a good afternoon. Cheers.
Thank you again for joining us today. This concludes today's web conference. You may now disconnect.